Welcome back, everyone. I hope that you all got some good lunch right now. You guys can eat while you're listening as well, so feel free to do that. And with that being said, welcome to Inspiration Hour. So every single day there will be one speaker for Inspiration Hour, and they'll be telling about their academic, personal, and professional journeys with you all. Please hold questions until our Q&A session, which will be happening around like 1:10-ish. However, our speaker here, if she has interactive activities, we really encourage you all to participate. Again, please be respectful, stay on topic or on task in the chat. And, send her a lot of love, send her a lot of hype. So, with that being said, let's meet our speaker today, Sahana Kumar. So, Sahana Kumar is a second-year medical student at UC San Diego School of Medicine with a clinical interest in surgery and a research interest in the utility of 3D printed and VR tools to improve patient education and clinical decision making. She is an honors graduate from the Johns Hopkins Whitting School of Engineering with a degree in biomedical engineering. While at Johns Hopkins, Sahana worked in neurobehavioral and patient care at the Kennedy Krieger Institute, led 3D printing healthcare startup Health 3D, and worked with the Center for Hope. She is a passionate advocate for hands-on extracurricular STEM education and has engaged in STEM service across San Diego County as well as throughout Maryland, most prominently with the Society of Women Engineers outreach team. She is a proud alumni of First Team 2485, where she served as software president. With that being said, please give it up for Sahana.
Hi, y'all. All right. I am really excited to be here, and I guess I'll just get into it. Like we were saying, I have a lot of interactive things for y'all to do, so I would appreciate your participation, and it's very fine to be wrong with any of these. I'm going to give you activities, and a lot of them are real activities I did in school when I was like in college. So I don't expect you to be great at them, but like all of your ideas are worth hearing, and I would love to hear them. There's no such thing as a wrong idea or a bad idea on what we're working on. Sound good? All right, I'm going to share screen. Let's go back. Can y'all see this okay? Got a slideshow?
Almost, maybe. It's black still.
It's
Oh,
take.
the screen's black? That's so fun for me.
I think you just gotta give it a
That's
second.
not right.
Probably just sharing.
This is, I can't lie, this has never happened to me before.
Well,
Um,
we've had a lot of firsts here today. So
It happens.
uh, what if we stopped it and started it again?
I
That's what my engineering degree taught me, I hear. Uh,
unplug it and plug it back in.
Pretty much. Maybe this. Oh, can we see it now?
Not yet. It said that you started screen sharing.
This is so
Um,
thrilling. Have y'all been able to screen share okay?
Uh-huh.
If I
Yep,
send the link, would we maybe be able to open it?
yep, yep.
Okay, let's try that
I
because
can screen share for you if you
okay,
want.
perfect. Let me open this up. Is it wait, are we still going or are we
Yeah, yep.
okay, perfect.
We're here.
I love this.
Hmm.
This is like a fun little
Of
reminder, I
course,
guess, that
problem
you can
solved.
go get an engineering degree and have tons of technical
There
difficulty.
you go. It's you, but you can figure out in probably less time than some of those old white-haired men.
Well, I've
I did
sent a
say that.
slideshow link in the chat, so maybe you can open that one up for me.
There we
Okay.
go.
Hey, awesome.
Awesome. Just let me know when you want me to turn the next slide and I could do it.
Perfect. Well, my name's Sahana, and we'll just get into it because I think y'all have heard enough about me already. Next slide, please. Sorry, if you hear loud noises, it's because I have a cat who's really intent on tearing up my couch. Anyway, so I got my degree in school in biomedical engineering, and before we hop into how I did that and a little bit of my journey, who here knows what a biomedical engineer does? Any ideas? Guesses? Yeah, I think I see Annabelle's hand.
Is it like biological medicine or something?
Yeah, that's a good idea. Medicine is definitely a huge part of it. Someone put, Alana, I think, put in the chat, creating medical instruments. That's also part of it. Anyone else have any other ideas of what a biomedical engineer might do?
Do you build like cells or like some other stuff? Not like cells, like you know what I mean, like DNA maybe. I don't know.
Yeah, like culturing cells can be a huge part of this, creating live tissue samples for things like right now, if you need a heart transplant or a kidney transplant, where does that come from?
A person.
Yeah, it comes from a person. And that can be really hard because it means that either a person has to give up something like a live kidney, or in the case of something like a heart, someone has to pass away for you to have that heart. One of the things, the cool things that biomedical engineers are working on is trying to engineer 3D printed,
Oh, yeah, organs. Yeah, I've heard of that.
and that can be pretty cool. Anyone else have any other ideas? Using engineering knowledge to solve medical problems. I think Ashley got the really wide arching one. That is basically the definition of engineering, biomedical engineering, using like the engineer's skills to solve a medical problem. And I think Charlotte had an idea. We'll take one more.
Yeah, I was kind of thinking the same thing, like you improving medical devices with engineering.
Yeah, it's a great one, improving medical devices. And Veda?
You use like engineering concepts to build and create new ideas in incorporating medical problems.
Awesome. Exactly. So medicine is one of those fields we want to keep learning and growing and evolving so we can help make people healthier, right? And to do that, we need engineer skill sets because at the end of the day, the fundamental job of an engineer is to be a professional problem solver, and that's pretty cool. And so I've known since I was a really little girl that I wanted to be a doctor, but I wanted to be a doctor who understood how we solve problems. I wanted to have the thought process that engineers have. Can we go to the next slide? Here are just a couple things that we work on as engineers. The first one is surgical robotics. This can be anything from robots performing parts of surgeries to people using robots kind of in a similar way to you might who's seen like one of those movies where you have like this giant robot like I don't know, crushing up a city or something and there's a person inside of it controlling a control panel. Anyone? There are a lot of those, and surgical robotics is the less destructive sister of that. Instead of someone inside a robot using controls to maybe break up a city, you're using a robot to get into really niche, precise areas of a human body that are harder to do with your own hands. The thing is that people's hands probably shake a little. We make mistakes, and robots help us kind of smooth all of that out. We also have things like tissue engineering, which is what I talked about before, generating cells that can create new hormones, generating things like, I don't know, you have cells that can produce certain types of proteins, doing examples and experiments to find out how different diseases affect the body. That's really important when we think about medications. On the kind of sister side of that, vaccine engineering and medication development, creating new pharmaceuticals and new vaccines for even something like the flu shot that you get every year. It has a huge role in bioengineering in how we build those vaccines. Public health and health data analytics. If there's something like COVID that's impacting a huge part of the population, we need to analyze that data and find out ways to do things like stop the spread of a disease. Genomics. We want to be able to understand how people inherit diseases so we can counsel families on what their kids might have, right? If everyone in the family has had a similar disease that presents when they're really young, then we might want to know about that. And that's always really, really helpful. For example, my family, thyroid disease runs in our family. Who knows what a thyroid is? Veda, I think I see you raising your hand.
Yeah, it's like near your throat when like a lump or something appears.
Oh,
Um, it's it can be based on different reasons like genetic or it could also be problems including like cancer and other things.
yeah, that's a great start. So a thyroid is a gland that lives here and it produces certain proteins that help your body function normally. And a lot of people have issues with their thyroid where it produces either too many of those hormones and makes you feel sick or too few of those hormones and that also makes you feel sick. So that one runs in my family and learning things like and just like things like being able to tell doctors that, oh, like if a family has the risk of having this, like more people might have it, that's like a really useful thing to know. Computational biology. You want to do things like model cells in fake environments so we don't have to put the resources into actually having a real live cell culture, which requires pretty constant feeding and things like that. And patient services. You want to make patients have a more comfortable experience. Who here's gotten a shot? I would bet most of you. And I would bet that maybe that's not the most comfortable experience in the world, and maybe you didn't have the best time getting that shot done. And so part of biomedical engineering can also be making sure that when you're in a scary environment, like getting a shot or an IV or getting your arm set in a cast, you feel better. And we are able to like kind of minimize the stress and the pain of that process. Make sense? We good? Okay, next slide, please. Okay, so before we get into how you become a biomedical engineer and how you become a doctor, I'm going to have all of you play the biomedical engineer for a second and give me some ideas. So I have a couple problems here, and we're going to try to solve them together. Sound good? So the first problem is surgical tools. So to do a surgery, you need a whole bunch of tools, and I put in a picture of some of those there. You have things like scalpels, which are like little knives you use to cut the body open so you can see what you need to see. You have grippers and things that help you suture, which is tying up a incision when you're done, and things that help you kind of burn away tissue so it doesn't bleed too much. But here's the problem. Historically, we've had way more male surgeons than we have had female surgeons. And if you talk about men and women, who has bigger hands? Usually, typically. Men. Yeah, a lot of you are putting that in the chat. And since men have bigger hands, surgical tools are made for people with larger hands. That works out really well for someone like me. I have big hands naturally, so it doesn't really matter for me. But it doesn't work out really well for a lot of women who are built smaller and have smaller hands. Why would that be a problem to have smaller hands if maybe the tools you're working with were made with for someone with bigger hands? Someone said worse grip, someone says too heavy, someone says hands flipping out. All of these are really good ideas, and that's kind of what it is. You can have less precision, you can have slippage, and the too heavy thing here is a huge thing. If you're operating, who knows how long you typically operate if you're operating one day? How long do you spend in an OR on a typical surgical day? Yell them out. Give me a couple ideas. Someone said 2 to 5, someone said 7, someone said 4, someone
8
said 5,
hours.
8. It's usually anywhere from 8 to 12 hours. There are shorter days, there are longer days. Some people might only be in there for a couple, but usually it's 8 to 12 hours. You usually show up for a surgical shift around 6 a.m. and you are operating, not always consistently, but you're operating in some capacity, and you might not leave the hospital until 6 or 7 p.m. that night. And that's a lot of time to be spending with a tool that isn't designed for your body. And if something's too heavy, if it's not quite the perfect fit, that type of thing matters for something as precise as surgery, right? And so problem number one is, how do we make sure these tools fit every single body, knowing that we have a wide range of hand grips and hand positions and preferred positions? What can we do? How would you start approaching that problem? Annabelle?
You could make them in like different sizes. So like there's like a large, small, and medium.
That's a good idea. A lot of people are putting in different sizes. Does anyone else have a different idea for a first step? Ashley?
Maybe you could make them lighter.
Maybe you could make them lighter. That's another good idea. Kiana?
You could like make maybe like the handles, like you can make them adjustable, like you have different sizes for handles.
Yeah, that's a great idea. Veda?
Maybe find a size that's not too small but not too big, like one size fits all, more than having a larger size.
You could try that, yeah. Here's the first step that I would take. I would always talk to the people who are using these things, right? Because we all have opinions on what might be difficult when we look at a problem like this. But the truth is that you don't know how specifically it's difficult until you talk to someone who has the problem, right? So whenever you think about like an engineering problem, I would encourage you to have your like first step be with something like research. What is the problem? Is it slippage? Is it weight? Is it wrist cramping? Is the tool itself working in terms of its grip, or do you want to maybe modify the grip so it can be more comfortable for long surgeries? What do you want to do? And then all of these ideas are great ideas on how you could actually implement a change. But the first step I always want you to think about when we look at any of these problems is asking more questions, because you're never ever in life going to say that you have too much information for an engineering problem. All right, can I have the next slide, please? All right, pulse oximeters. Who knows what a pulse oximeter is? Anyone? Lisa?
It's a thing that measures your heartbeat or like the oxygen in your oh wait, no, it's the oxygen in your blood, I think.
Yeah, perfect. It's something that measures the percent of oxygen in your blood. Anyone know how it does that? That's a little bit of a harder question. Annabelle?
Does it kind of like see like squeeze it kind of?
There
And
is some
like
pressure involved, yeah. Athena, you got an idea?
I was thinking maybe it checks maybe like it checks like the blood pressure like that's in your like fingers and stuff, and like maybe like even like your heartbeat a little bit, and like it'll like help determine the thing.
That's a great idea. Let's take one more idea. Danielle?
Does it use sensors to check your pulse from your finger to see maybe an estimate or a guess?
Good. Those are all great ideas. And some that I've seen in the chat as well are things like microneedling and taking samples of your blood. It does not do those things. It is not painful. It doesn't like prick you. What it actually does is it shines a little light through your finger. And the thing is that blood with tons of oxygen is going to absorb light differently than blood with not that much oxygen. Because really, like in your blood, there are proteins bound to oxygen. And if there isn't enough oxygen in your blood, some of those proteins will be empty. They won't be carrying anything. Kind of like if you see a ski lift and there's a difference between the ski chairs going up with people on them versus like some are just empty. If there are less people, there'll be more empty ski chairs. And the same thing with blood. And so this shines a red light through your finger, and it measures the amount of light that comes out. And based on that, it does the math and figures out how much or how much oxygen is in your blood, and it can make a little percentage. Does that kind of make sense? The concept, at least? Okay, so because of the way that that works, the truth is that darker skin absorbs light differently than lighter skin. And because of that, historically, we've always calibrated pulse ox machines to work best for lighter skin because that was what we cared about more historically. Because of that, people with darker skin get less accurate measurements, and sometimes we think they're healthy when they're actually pretty sick. And why could that be a problem, thinking that someone's healthier than they are? Sorry, this is my cat, Juno. She wants to say hi. Is it Zoe?
Yeah. If we say they're sick when in reality, or they're not sick when in reality they are, we could prescribe them wrong and they could end up either dying or getting even more ill and spreading it throughout other people.
Yeah, they could be sick. They could stay sick. We couldn't get them treatment as early as maybe they need treatment. And all of those can be problems. And we can give them the wrong treatments. We can give them a treatment for a less aggressive disease when maybe they have a more aggressive one. Anyone have an idea on how we can maybe fix it? Charlotte? Oh,
Maybe using like a different type of light or something.
yeah, perfect. There are different types of light that can work better, and that's a lot of the research that's going on right now. Another option you could have as an intermediate is figuring out how much light that darker skin absorbs and correcting for it, having a correction feature that grades people based on the darkness of their skin. With that said, you would have to have a way to always be able to put in like the correct shade in order to get an accurate enough measurement. But different types of light are what people are working on right now, and absolutely calibration measures as well, and calibrating to a specific person. Make sense? Okay, next slide, please. All right, let's talk about neonatal dehydration. And I feel like I'm getting a little behind schedule, so we might end here. We might not go on. Actually, we'll go on to the next one. We'll skip this one. It's not as interesting as the next one, and I want to give you a chance to look at this one. All right, anyone know what craniosynostosis is? Ashley? Oh,
Isn't it when the parts of the skull they get stuck together before they're born?
perfect. Very, very good. Um, who knew that when you were born, your skull is actually open? Anyone knew that? I can tell you this, when I started college, I did not know that babies are born with their skulls wide open. And they're open along these lines called sutures. And basically that lets the brain grow. But for some babies, they're born with those sutures, those openings already fused. And because of that, when their head starts growing, you get these like characteristic kind of like protrusions because the brain is pushing against the skull and trying to bend it. And that can, of course, be really dangerous for the brain because you don't want like a little baby brain getting shoved up against this really hard skull. It can cause compression, it can cause maybe some brain damage, and we never want that. So, what do we do to fix that? Anyone have an idea? Olivia?
Maybe we could perform a surgery after they've been diagnosed to take away parts of the skull so that the
Yeah,
brain has more room to yeah.
that's pretty much exactly what we do. We go in and we open that fused suture. We don't take away any parts of the skull, but we just open it up. And then we want to create that space that should naturally exist, but it doesn't because we're just cutting it, right? So what we do is we put in a little spring, and we put in little springs along the skull, and that's called cranial vault remodeling, the way you see there. And that lets baby's head grow normally. What's the problem with putting little springs in your head? Veda, got an idea?
Springs are made of metal, so it could rust over time.
That's a good idea. We have actually made anti-rusting screws for this process. So
Ah,
you actually could have them in forever if you've ever heard of someone who has like a plate in your knee. But that's a good idea that did happen once upon a time. And that's why an engineer once upon a time made like screws that don't rust and can stay in your body for a long time. Kiana, got an idea for us?
I think they can move in the head, which can cause damage to the brain or
Another good
head.
idea. We do fix them in place. There are no screws rattling around baby heads, but that is a very good idea. I think we'd get a malpractice lawsuit if we had screws rattling around baby heads. Emma, do you have an idea?
I was just thinking that it's not like metal springs can grow with the skull and brain, so they could eventually eventually they would be too small and yeah.
That's a good idea. And that could happen. Your head is grows less than the rest of your body. At some point, like those sutures do fuse and your brain kind of slows down in its growth rate and things start growing a little more gradually. So your skull is able to kind of keep up, but that's a really good idea. Okay, we're gonna take one more idea, and I think I'll take one from Sydney.
If it's done improperly, they could be prone to infection
Mhm.
or possibly just it not done correctly and not working well with their skull.
You are 100% right. If it's done badly, it's a very bad procedure. But usually we try to hope that our surgeons will do their procedures right as we go in. But that's a good idea. If you're right that it could cause infection and it could cause problems if it's done improperly. It is risky to operate that close to the brain. Here's a simpler reason. Are all of y'all's skulls closed or do you have openings in your skulls? What do you think?
They're closed, right? They're closed. And if we put springs in there, it's really hard for a skull to close. And at some point, we want your skull to close so that when you're, let's say, older and playing soccer or basketball or just playing on a playground and you fall, your brain isn't just open and getting all of that shock. And so we need to go back in when the toddler's older and take out those screws. The thing is that that is an extra procedure. It carries risk of infection, like some of y'all talked about. It carries risk of doing a procedure wrong. And it's just kind of like feels like a pretty unnecessary reason to open someone's head back up. But we have to do it. And what could be a way to prevent that second surgery to take those springs out? Veda.
I'm finding like a screw, not like a screw, but like a spring that dissolves over time, kind of in the head, so you don't like how like now like I think stitches you don't have to go and get them removed. They like fuse with the skin together, something like that inside the head.
That's perfect. That's exactly what we people are working on. That's called what the sutures that you're talking about are something called a bioresorbable suture, a suture that can come back. And what we are working on right now, and it hasn't been made yet, it's something that people are still working on, is a screw that will slowly dissolve so that you don't have, in like a body safe way, so you don't have to go back in and get that skull back out. All right, I see questions, and I know y'all have more questions, but like I will take one of them that I see right here because it's a good question. Someone said, let's say a child had this procedure and their skull is open. What would happen if they had a severe concussion? Would the brain be damaged? Yes, it would. That is also what happens. So, a concussion, medically speaking, is just a brain bouncing against the sides of your skull and basically getting bruised. But the reason that we have to be really, really careful with little babies is because if they fall on their heads, they can get their head kind of damaged. Their brain can get damaged because it doesn't have that same protection that an adult brain might have. It's why people always say to be careful with babies. It's why you have to be careful about dropping babies. Because they can get hurt a lot easier than like I've seen so many 6-year-olds just fling themselves off a playground and end up totally fine. But you have to be more careful as a baby because your skull is still going through that. So it would be about as risky as like a general baby who had a fall like that. You never want babies to have that. Someone else asked what would happen if you grew to adulthood and didn't get that care. If you didn't get that care, basically what would happen is your brain wouldn't have anywhere to grow against and it would get bruised from like trying to expand and grow against that fixed surface. And you would probably get pretty bad brain damage, and that could affect a lot of different things as you grow older. Anything from your vision to your cognitive ability to maybe your speech to like your hearing, everything goes through the brain. So you can lose a lot of different things, and it's really hard to say which ones. All right. Are we good? Are we a little engaged after lunch? All right, let's go to the next slide, please. All right. I feel like the most common question I get when people ask me about being a doctor is how long does it actually take to do this? So I did my 4 years of undergrad. I went to Johns Hopkins. I got my degree in biomedical engineering. You can take some gap years. I took 0 gap years because I didn't feel I needed any. As you'll see in the next couple slides, I'll tell you a little bit of my path. And I did a whole lot of work so I wouldn't have to take those gap years. But the oldest person in my class is 49. I think she's 50 now. So she took 20, 30 gap years between when she finished college and when she came to medical school. So you can really take as long as you want, and your journey can take as long as you want it to. Then medical school takes 4 to 5 years. A lot of us take a gap year. And then residency is what you do after medical school. So you're finally getting paid. It's your first like real doctor job, but you're still a trainee because we don't want people fresh out of medical school having to make big clinical decisions that impact people's health and their lives on their own. So they end up making those decisions with other people, and they get the supervision of doctors who've been doing it for a lot longer, and we call that residency. And that can mean something like pediatrics and surgery and radiology and a whole bunch of different fields. And then you have something called fellowship if you want to be super, super specialized. Let's say you want to be a baby surgeon specifically. You want to operate only on like kids. Or let's say you want to be a cardiologist specifically. You do a fellowship to train in that very specific part of the body rather than having like what we call a generalist skill set, knowing a larger variety of things. We want you to be like really honed in on treating one specific type of disease. All right, next slide, please. I'm going to tell you a little bit about how I got here, and that starts around when I was about y'all's age. I knew from a really young age that I wanted to be a doctor, because I got to, who knows what an umbilical cord is? Lisa?
It's a cord that like connects you to the placenta when you're like in the stomach.
Yeah. When a baby's in the uterus and still growing, they're still a fetus. The umbilical cord carries nutrients, oxygen, everything baby needs from mom to baby because they can't get any of that by themselves. I got to, and like when a baby is born, you have to cut it. So I got to cut my little sister's cord when I was 4 years old, and I knew then that I wanted to be a doctor. But being an engineer, it took me a really long time to know that I wanted that. And I found it out when I was a freshman in high school in 2016, and I really wanted to work in a lab for the summer. I don't know where this dream came from, but I decided I wanted to do research as a 14-year-old. So I emailed a whole bunch of labs at UCSD, which is, I lived in San Diego, it was close by to my house. And suddenly someone told me that they would take me. And I did research printing congenital heart defects, which are structural defects in the heart that some people are born with. And that kind of helped parents understand like why their kid was in the hospital and maybe needed a surgery. And I fell in love with that project, and that was what made me fall in love with engineering. I loved working with a big team. I loved really getting to problem solve for families and make their experience in a hospital easier. And this is little 14-year-old me doing some congenital heart research and presenting my research for the first time. It took me a very long time to print that heart over there. I was very proud of it. All right, next slide, please. I loved it so much that the next year I went back. I did cell signaling pathways. And around this time, I was feeling real good. I was like, I'm going to be an engineer. I'm putting that whole doctor thing to bed. I don't think I care about being a doctor that much. I love engineering. And so I did some research on cell signaling pathways, which is how our cells talk to each other and make different bodily functions happen. And I did what's called computational biology research, where I used different types of mathematical equations to model how these cells talk to each other. And I felt real good. I had a real good time. And next slide, please. 2018, I got a reference from that same lab to go up to Stanford University for the summer. Stayed with my godparents for the summer. I got to model pulmonary arteries and how they grow, which helps us kind of figure out if you don't know the normal state of something, it's really hard to know when something is in the disease state or if someone's sick. And we didn't know that about pulmonary arteries and how they grew as you got older. Some parts of your body kind of stay the same size your whole life, and some things grow with you. And we didn't know if pulmonary arteries grew with you or if they kind of stayed the same size. And pulmonary arteries are the arteries that go through your lungs and get blood oxygenated and like drop off basically deoxygenated blood and collect oxygenated blood. Again, feeling real good about the idea of being an engineer. Here's another really awkward picture of me in high school. And next slide, please. Okay, so this is my senior year. I've gotten into Hopkins. I'm going there to study biomedical engineering. I'm feeling real good about my future. And I'm thinking, okay, let me do like a real engineering project. So I go back to UCSD and I email a professor at a nano engineering lab. And I decide to spend my summer building batteries, flexible batteries. And I hated it with my whole heart. I thought it was the most boring thing I'd ever done in my whole life. I spent that whole summer miserable. I did not like batteries. And now suddenly I was in a conundrum because the second I stepped away from medicine, I was like, I don't really know if I like this engineering thing all that much. And so I was a little stressed out. Next slide, please. So I did my first year at Hopkins. I studied biomedical engineering. I really loved my major. And I got an engineering internship for the summer at Carnegie Mellon. But it was also 2020, so COVID hit. So my engineering major shifted focus to something called autonomous warehouse planning, which is about as interesting as it sounds. Some people would love it. I had a terrible time. I didn't like it. I was really, really bored the whole time. And that was what made me realize that the type of engineering that I loved and the type of work I love to do fundamentally like kind of revolved around patients. The thing that I really loved doing was talking to patients, improving a patient experience, learning more about how we can treat people so we can make them healthier. And that was when I started to revisit the whole doctor thing in my mind. Next slide, please. That year, Hopkins also needed face shields because we had a huge shortage of what's called PPE, equipment to protect doctors from getting sick. And I did some research with them and I went back to the patients that I'd always loved and I got to do work with healthcare providers and patients and I really, really enjoyed that work. And so that was kind of how I fell in love with biomedical engineering again, but also how I kind of started thinking maybe I do want to be a doctor after all. Next slide, please. I also that year started working somewhere called Kennedy Krieger. I worked in an inpatient pediatric unit with kids who had really, really severe autism and were in the hospital because they needed behavioral treatments to be safe at home. And I fell in love with that work. That was what made me realize that I wanted to be a doctor. I loved working with kids of any age, basically. I loved getting to watch them get better. I loved getting to watch them go home. It was one of the single most rewarding experiences of my life. And I really, really loved working with families. I think that's like being an engineer, you get to make a huge impact on lots of people that you never see. You get to maybe build a phone for people like that thousands of people will use, but and maybe millions, but you won't ever see their faces really. But being a doctor, you get to impact two, three, maybe 20 people a day, but you really get to see that impact. You get to watch like families cry happy tears because they get to watch their child come home. You get to watch people who maybe thought they'd never walk again take those first shaky steps and support them through that. You get to support people through the best and the worst moments of their life. And that is such a privilege. And that's why I love my job every single day. That's why I love being a medical student. I love getting to go in and watch families get better. I love getting to watch families come together. I love getting to watch people heal. Because the truth is that I know that every time I'm in a hospital, no one wants to be there, right? I bet that none of you think that when you go to the doctor's office, that's like the best time ever, right? You're probably like, I have to do this thing so I can get back to living my life. But the cool thing about being the person in the doctor's office is you get to help people go back to their real life. You get to help them meet their goals, whether that's, I really want to play with my grandchildren, but right now I can't run. Or I really want to eat this food, but I have this like I want to be able to eat food without stress, but I have these really persistent allergies. Can you help me? Or I really can't sleep at night because I'm having a hard time breathing. Can you help me like find a better way? And all of that is such a privilege to get to watch people go back to their real lives. And that's something that only medicine does. And being able to work with patients, work with families, it is such a gift and such an honor. So doing that for me was like when I was like, okay, I guess I'm being a doctor after all. All right, next slide, please. 2023, I got into medical school. It was the best moment of my life is I have a picture there of my white coat ceremony. That is me suturing a pigskin graft, learning how to put in stitches. And that's a picture of me giving a talk on healthcare disparities to the rest of my classmates. Medical school is the single most rewarding thing I've ever done. People ask me all the time, it takes so long. Why are you doing this? And the thing I'll tell you about that is that never decide not to do something because you're scared of how long it'll take. Because it's always better to put in the time and put in the hours into doing something that takes a really long time, but you love at the end of the day, than to go through something fast and end up in a job you hate for the rest of your life. 8 years of training is a lot of years of training, but it's better than 4 years of training and ending up doing autonomous warehouse planning for the rest of my life. So I'm very grateful for my degree. I'm very grateful for the time in medical school and the people that I've met. And I love my job, I guess is the end of that. Um, and now I'm gonna let y'all play doctor for the next 7 minutes and then we'll take some questions. So could we get the next slide, please? All right. Our first case vignette. We have a 13-year-old named Jordan who gets tackled during a football game and feels really dizzy afterwards. He keeps asking the same questions over and over, doesn't remember a touchdown he scored. Who thinks they know what caused that? Olivia, you got an idea?
Maybe a concussion to like the frontal lobe of your brain or something?
Good. Yeah. A concussion, we don't usually like localize like that to the lobe, but you're right that it could be some damage to the frontal lobe. You can have some memory loss, you can have dizziness.
Maybe a concussion.
Yeah,
Oh, Lord.
exactly. You can have dizziness, you can have nausea, you can have kind of a delayed return to activities, and it can be really hard to study and read. Anyone have an idea of what treatment we might give Jordan? How do you treat a concussion?
Ice pack. Oh, my phone.
Ice pack is a good idea for any kind of pain. Any other ideas?
No like screens or like light.
Good. Light and screens can be really, really hard on the body and the brain.
Time to heal.
Time. That's the million-dollar answer. Concussions, unfortunately, are healed mostly only by rest. Your brain will regenerate given time, but it needs a little break for a minute. And that can be hard to handle. It's no one's favorite answer for how to heal, but it is the truth. All right, next slide, please. All right. Layla, who's 12 years old, eats strawberries at lunch and her lips swell. She gets hives. She's feeling tightness in her throat. Who thinks they know what caused that? Alice, you want to tell us?
She probably has an allergy.
Good. She probably has an allergy. Who knows what causes allergies? Why do we have allergies?
When your body isn't able to handle a certain food.
Good. Anyone know why? Why can maybe Layla not eat strawberries, but I eat strawberries every day and I'm totally fine? Kiana, you got an idea?
It's when your immune system decides that it just doesn't like strawberries. I guess it decides it's like an enemy.
Yeah,
So
exactly. Your body, for whatever reason, has decided that strawberries are a threat. We don't like strawberries. We're freaking out by them. So, your body has different types of immune cells, and what creates an allergic reaction to something like that is something called mast cells. Mast cells are cells full of something called a histamine. And histamines are things that bring immune modulators to your body. It's like, okay, threat at your lips, threat at the throat. Let's bring a whole bunch of immune cells here. And that causes redness and warmth and itchiness, actually, because your blood vessels are dilating to make room for all those cells rushing to the area where they think something has happened. And that's why you feel itchy. It's trying to help. All right. And who knows how you treat an allergy? Do mast cells apply to outdoor allergies too? Yes.
EpiPen, if she has one.
EpiPen if it's a really severe allergy. What about a less severe allergy? What about someone who's not maybe anaphylactic, but they have a little bit of an allergy? What can you do? Zyrtec, Benadryl, anti-allergenic medicine. Yes, these are all called antihistamines. And I just told you about the histamines that are released to bring a bunch of immune cells all to your body. And those are, we kind of bring in the antihistamines to kind of block what they're doing. We're like, nope, don't do that. And actually, Advil and things like that, if you've ever taken maybe Advil for a headache or Tylenol, we don't really know how it works, but Advil for a headache, they work a very similar way by preventing a different type of immune protein called prostaglandins, which also cause that heat and that pain and that warmth in an area where your body thinks something's happening. Make sense? All right. Let's actually go maybe two cases ahead. I know we're running out of time and I want to give you guys time for questions. So, one more, I think. All right. This is kind of a gross one. Are you ready? Anyone get grossed out easily? Okay. If you do, you might want to look away on the next slide, but we'll stay on this one for a minute. Amina is a 13-year-old girl living in a rural village where clean water is hard to come by. Start of the summer, and she notices a painful, burning blister on the bottom of her foot. A few days later, the blister pops and something white and thread-like starts poking out. It hurts even more when she puts her foot in cold water from a pond. Anyone have an idea what's going on with Amina?
I think she might have gotten an infection or some disease from the water.
Infection or
More
some
likely.
disease? Athena, you got an idea?
Like infection.
An infection, good. All right, I see some people putting in a worm, and it is in fact a worm, which is a type of infection, so all of you are right. This is a worm called Draculancus. It tends to penetrate the bottoms of your feet while you're walking. It comes in and it kind of rests in your skin and it forms that shiny blister, which is really just from like the worm sitting there. When it pops, the worm comes out, and you actually have to you soak it in like a pot disinfecting water. The worm starts to come out, and you take a matchstick, like a little stick, and you wind the worm around it until it's all the way out, and that's how you take them out. It's a little nasty, but that's how Draculunkus works. Luckily, it's not too common in the US. We mostly see it places where it's hard to get like clean water and there's just like way more of it. I have not ever had to treat it. It is pretty rare in the US, thank goodness. So I have yet to see a Draculunkus infection. I have seen some tapeworms though, some intestinal worms, which can cause you to lose weight pretty quickly, and you usually find out because you start seeing some wiggly things in your poop. It's called Draculunkus. And can we go to the next slide and close your eyes if you're a little squeamish? So that blister on the side of the guy's foot in the photo on the right is kind of what it looks like. And then the picture on the left is actually a horse that has that tapeworm. So that white stringy thing coming out is Draculunkus. It's pretty big, but it can be pulled out pretty easily. It's actually not that hard to treat. It's just a little creepy and it never feels very good to have. But yeah, it is 1:21 and I promised I'd give you time for questions. So next slide, please. And the one after it. Okay, here are a couple things that you can do if you're interested in STEM, but I'm sure Dr. Mimi will tell you plenty of them. And the next slide. Thank you so much for coming. And okay, I have time for all of the questions now, so let me know. And if we have time afterwards and you guys run out of questions, we'll do more vignettes. Charlotte, I think I saw you first.
What is your favorite moment as a doctor?
My favorite moment ever as a doctor, not quite there yet, but my favorite moment as a student, I suppose, was there was a little boy who had autism spectrum disorder. And when he was 12, his dog died, and that triggered a mood disorder. And a mood disorder is what we call things like depression or anxiety when we can't really maybe our patient can't communicate enough, or we can't quite identify exactly what the problem is, but we know they're having some issues with their mood and regulating their mood. So this little boy had that, and that really exacerbated some of the behaviors he had with his autism. He was pretty okay before that, and suddenly he wouldn't eat anything. He couldn't take a bath because it hurt too much. He was really hurting people around him, and he was hurting himself too. He would like hit himself on the head and things like that. And he was just really unhappy, which was really hard to watch. I met him when I came onto the unit the first time. I was 19 years old, and we kind of formed a bond because I found out the one thing that would calm him down was me singing. He never found out my name. He only called me Singer. But I'd come in and I'd sing to him until he kind of like had a trigger for his mood disorder, and he'd start like hitting himself and hurting me and all of these things. But we found a therapy for him called ECT, which is when you actually take the brain through a controlled seizure by stimulating a part of the brain. And it can be really, really effective for mood disorders, even though it sounds kind of scary. So we started treating him with that, and I'll never forget the first week after he'd had his first set of treatments. I walk in, and this little boy who I've never seen smile, has always been grumpy, has always been everything. Like, I've just never seen him happy. He was so sad all the time. He sees me, and this giant smile lights up his face, and he runs up to me and he demands to be picked up, and I swing him around, and he's like, "Oh my gosh, you're here. I missed you." Um, and so we hung out, and that was really, really fun. And it was so fun over the course of the next few months to watch him get better. And his goal was always to go back home to his mom. And even though it broke my heart a little bit when he left the unit after a year, it was so beautiful to watch him go home to his mom and go on with his life. And I always tell my patients when they leave the hospital, I never want to see you again because I always want them to like go on and live their lives and be healthy. I don't want to see them back in a hospital just so I can hang out with them. And so I never saw him again, and I'm really, really grateful. And I'm so happy that he's getting to just live his life. It was a really special moment for us to all watch him kind of get better and for our collective effort to be the thing that got him better. All right. Ashley?
Currently, in like your research, are you working on anything that you think has like a lot of potential in the future?
Currently in my research, some of my research right now is in 3D printed models and how we can use that to kind of educate patients on what they have. Because I always say that like you want to be able to make an educated decision as a patient, right? If you have like some kind of health condition, you want to be able to like know what's going on with your body So you know the treatments that the doctors are telling you can get, and you can make an informed decision. Because the truth is that like there's no one way to treat something. It depends on what your goals are, it depends on what you want, but you can't expect patients to come in knowing already all of those things. I had to go to school for 8 years for this. We have to teach them about their disease in a few minutes so that they can make an informed decision. And I think 3D printed models that can give people the ability to really see what's going on with their brains or their hearts or whatever part of them maybe needs some help or some surgery or some medication. And using those as tools to teach them about their own bodies is kind of the future of how we empower patients to make the best decisions for themselves. Because the truth is, at the end of the day, I have a lot of knowledge, which is great. And that's what I trained for so long for. But you are the expert on your own body. And you should always have the ability to make the decisions about what happened to your body. And as a doctor, the only thing that I could really ever hope for my patients is being able to empower them to make the decisions that are best for them and their bodies instead of maybe the decisions that I think are best for them or I would want made from my body. All right. Charlotte, I think I see you next.
If you have an allergy, but it didn't appear till later in your life, what changed?
It depends. Sometimes your body gets hypersensitized to something because maybe you were already sick when you had something. Sometimes if it's something like some people become lactose intolerant. That's because it's a certain bacteria that helps metabolize it. And maybe you get something like the stomach flu that like really wipes out all of that bacteria in your gut microbiome. And so it's really hard to like those bacteria are no longer producing the enzyme that they were supposed to. It can be a bunch of different things. Your body is actually a fairly fragile environment. It's really surprising that things go right as often as they do, considering how fragile it is. Yeah. Um, Athena?
What would usually happen to a small child if they accidentally got the wrong side of an EpiPen into their right thumb and wasn't having an allergic reaction?
Nothing too crazy. So EpiPens are what's called like our epinephrine. That's what you're like putting into your body. Does anyone know what epinephrine is or what it does? Maybe? So epinephrine is what's called your fight and flight reflex. And what can happen is it does things like constrict your blood vessels, so more blood is going to your heart, and we're helping like you run faster from the bear, for example, and things like that. And the only concern that can happen is if you like inject into a finger and the blood vessels to your finger like constrict in response to the epinephrine, which is what happens. You can maybe start losing blood flow to it, and we might have to take you to a hospital to kind of reverse that and give you something that does the opposite of epinephrine to make those blood vessels open up again and make sure you don't like lose any blood flow to your finger and have tissue die because of that, because tissue without oxygen always dies. Arya?
So I was interested in like pursuing biomedical engineering. So I was wondering what I could do in high school to help me prepare for that kind of.
Your classes are always helpful. I took physics, I took chemistry, I took math, biology, all of those things help me. I was on a robotics team, which I think for any type of engineering is super, super helpful because you get used to working on teams, you get used to working with other people, you get used to like carrying a concept out all the way to fruition. And all of that is super, super important. And what I did is I actually went to the like biology and bioengineering section of my local university, and it can be any university. And I sent, I think it was 100 emails to every single person at that department. And most of them didn't respond to me. A whole bunch of them responded and said, "No, you're a child. Go outside." And I was very persistent. And finally, one person responded and they said yes. And I show up the first day. And they think that I'm sick. They thought I was 16 and they were like, "You're 14, you can't do this. There are too many dangerous things in this lab." So I'm like waiting outside, wandering around, waiting for my mom to pick me up. And I feel really bad about myself and I feel really young and really dumb. And then This professor walks out of his lab and he's like, "What's going on?" Like I heard there was like maybe a high school student coming in because he worked like downstairs. And I tell him, and he's like, "You know what? Come back tomorrow and I'll set something up for you." And I came back tomorrow and he had found like a postdoc and he was like, "She's going to mentor you." And he had found me this little 3D printing project that their lab didn't care about. That's why they gave it to me. They didn't care about it. It was a throwaway project. And now that little throwaway project has four PhDs working on it at Rady's Children's. So sometimes you get lucky. But yeah, I was just very, very persistent and very stubborn. And I knew that I wanted what I wanted to do. So that helped me a lot. I think when you know that you're ready for something and you're old enough for something and you're ready to put in the work, then it doesn't really matter what anyone else thinks. You just have to be really persistent until you find one person willing to give you a very small chance and then run away with it.
To intervene just now, it is 1:30. We'll be opening up breakout rooms in a bit just for more discussion, and Sahana will be able to jump in and ask any more questions that other breakout rooms may have. Is there a good email that anyone can reach you at that you could put in the chat?
I am putting my email in right now. If you email me and I don't respond to you, just email me again. I'm not ignoring you. I want to talk to you. I just probably didn't see it. So just bother me again if you reach out to me once and I don't respond.
Amazing. And if we could all say a huge thank you to Sahana for her amazing talk and for answering a lot of questions.
Thanks for having me.
Tara, can we give us another second because I'm going to just collapse the breakout rooms 1 and 2 into one, etc. So that rather than change everything out. So ask maybe one more question.
Okay, we could answer one more question before we regrets. Maybe Kiana's.
And Suzanne, if you want to help me, that'd be great.
How can biomedical engineering assist
I can do that.
diagnosing and treating cancer?
Diagnosing and treating cancer. Great question. So when it comes to cancer, the future of cancer therapy is something called immunotherapy. Cancer genes all have specific, like they upregulate specific proteins that we can target. And historically, a huge problem with cancer treatment is that we use things like chemo and radiation, which maybe like they kill a lot of cancer cells, but they also maybe kill a lot of healthy cells, and that makes people feel really sick, and that's not fun. So the future of cancer therapy through immunotherapy is medications that target specifically cancer cells by targeting markers that that specific cancer is upregulating. And that starts by really being able to thoroughly sequence someone's specific cancer because person A's cancer, even if they, like, let's say person A and person B both have the same type of breast cancer. They have like a ductal invasive carcinoma in situ, which is a specific type of breast cancer. They can have different markers. There's a common marker called HER2, and maybe one person is HER2 positive, and maybe one person is HER2 negative. And so one person can be targeted using that HER2 marker, and the other person can't. And so when we look at these treatments, we want to be able to really, really specifically target people based on what they actually have. So that's kind of the future of cancer therapy. We want to make sure that we're not just like killing off a bunch of healthy cells and maybe killing the disease, but killing the person in the process. We want to make sure that we're really specifically targeting just the cancer and helping people stay as healthy as they can through that process. Because as I'm sure a lot of you know, cancer therapy can be pretty really rough for a family and a patient.